Before you move a blood pressure pill to bedtime or force down a large glass of water tonight, pause. Both ideas are repeated online as protection against a heart attack during sleep. Neither is a universal rule, and one may be exactly wrong for your medicines, bladder, kidneys, or heart condition. That does not mean the hours before sleep are irrelevant. A heavy late meal can worsen reflux and disrupt sleep. Loud snoring can be a sign of obstructive sleep apnea. Dehydration across the day matters. Excessive heat or cold can disturb rest and strain temperature regulation. But the safe evening routine is more personal and less dramatic than a list of commands tied to a clock. We will examine 5 bedtime habits in the same order they usually appear in heart warning videos. Stay for the second habit, because 2 large randomized trials changed what patients should be told about medication timing. The fourth answers the thumbnail question about bedtime water and blood clots. By the end, you will have a routine built around evidence, symptoms, and the instructions that belong to your own treatment plan. First, correct one frightening claim. Heart attacks and strokes do not occur almost exclusively during the quiet hours when protective systems are supposedly offline. The cardiovascular system continues regulating circulation during sleep, and blood pressure normally falls. Research has often found a morning rise in cardiovascular events around waking, rather than a unique peak from midnight to 6. Nighttime hypertension still matters, but it cannot be blamed on one ordinary evening choice. That distinction changes the emotional tone of the entire routine. A late dinner or warm bedroom is not a loaded weapon waiting for sleep. Cardiovascular events usually emerge from established risks that develop over years, including high blood pressure, tobacco exposure, diabetes, abnormal cholesterol, kidney disease, atrial fibrillation, and existing vascular disease. Evening habits can influence some of those risks or the quality of sleep, but they should not be portrayed as the sole trigger for a silent catastrophe. Blood pressure usually drops by roughly 10 to 20% during sleep. Some people show little drop, while others have pressure that rises at night. A clinic reading cannot reveal that pattern. When nocturnal hypertension is a real concern, a 24-hour ambulatory monitor can measure pressure during ordinary activity and sleep. Guessing from symptoms or changing pills without data is not the same assessment. The first habit begins at the dinner table. A large, rich meal close to lying down can leave the body digesting when the person is trying to sleep. Blood sugar and triglycerides rise after eating, and reflux becomes more likely when a full stomach meets a horizontal position. Discomfort, coughing, or fragmented sleep may then carry into the night. Meal timing also interacts with the body's circadian system. Observational research links late-night eating patterns with poorer cardiometabolic health, and controlled studies suggest that the body may handle glucose differently later in the day. That is a reason to examine a repeated pattern. It is not proof that dinner at 8 causes a heart attack at 3 in the morning. What is on the plate may matter more than assigning 1 hour to everyone. A salty restaurant meal can worsen thirst and fluid retention. A very large portion may provoke reflux. Alcohol can fragment sleep and interact with medicines. Highly refined carbohydrates may produce a different glucose response than a balanced meal containing vegetables, protein, and higher fiber foods. An earlier main meal may be practical for someone who experiences reflux or poor sleep after dinner. Another person may work late, need food with a medicine, or risk low blood sugar overnight. Instead of promising that every adult must finish by 6 or 7, test a realistic gap between the main meal and lying down. Note portion size, symptoms, sleep quality, and any instructions linked to diabetes or other treatment. The experiment should change one variable at a time. For several evenings, keep the usual foods but reduce the portion. On another set of evenings, keep the portion similar and move the meal earlier if the schedule allows. A simple record of burning, coughing, awakenings, morning energy, and glucose readings when prescribed can show whether timing, content, or quantity is the more useful target. The purpose is not to create another rigid ritual. It is to learn which part of dinner is actually disturbing the night. Chest pressure should never be dismissed as indigestion simply because it followed dinner. New pressure, squeezing, shortness of breath, sweating, faintness, or discomfort spreading to the arm, jaw, back, or upper abdomen requires urgent assessment. Reflux and cardiac pain can overlap, and a video cannot safely tell them apart. The first adjustment, therefore, is modest. Avoid turning the final hour before bed into the largest meal of the day when possible. Move more of the evening food earlier, reduce the portion if dinner must be late, and choose foods that do not reliably trigger symptoms. The purpose is better sleep and a healthier long-term pattern, not emergency protection from one perfectly timed plate. That measured advice leads to the second habit, where timing has been presented with much greater certainty than the evidence allows. Many people with hypertension have heard that morning dosing leaves the heart unprotected at night and that moving every tablet to bedtime can save a life. The concern behind that advice is real. Nighttime pressure and a missing nocturnal dip can carry prognostic information. The mistake is assuming that a change in clock time automatically corrects the pattern or improves outcomes for every patient. Different drugs last for different periods. Some are taken once daily, others more often. Diuretics can send someone to the bathroom. Multiple medicines may lower pressure too far while standing during the night. Blood pressure can also appear controlled in the clinic while remaining high during sleep, or appear high in the clinic while being lower at home. When the pattern matters, a clinician may use validated home readings or ambulatory monitoring rather than guessing. A 24-hour monitor records measurements at intervals across waking and sleeping hours and can reveal nocturnal hypertension, an absent dip, an excessive dip, or a morning surge. An influential Spanish study called Hygia reported very large benefits from bedtime dosing, but its results and methods drew substantial debate. More recent evidence provides a calmer answer. The large time trial found no advantage in major cardiovascular outcomes or mortality when usual antihypertensive drugs were scheduled for evening rather than morning use. The BedMed randomized trial later reached the same practical conclusion. Bedtime use was safe for many participants, but it did not reduce major cardiovascular events or death compared with morning use. This is the first major payoff. Evening dosing is not a superior default for everyone over 60. The best time is generally the time that fits the prescribed drug, avoids troublesome effects, and can be followed consistently. A clinician may still choose nighttime dosing for an individual reason, including documented pressure patterns or a particular medication plan. Another may move a diuretic earlier to reduce nocturia. The decision belongs to the prescriber and patient, not to a viral routine. Do not move, split, skip, or double a dose because the clock in a video says 7. Bring a complete list to the next visit and ask 3 specific questions. What is the intended duration of action? Is there evidence that my pressure stays high during sleep? Would changing the time increase dizziness, falls, bathroom trips, or interactions? Those questions make medication timing personal and testable. Include medicines that may not look like blood pressure treatment. Water pills, prostate medicines, nitrates, sleep medicines, and some drugs for pain or mood can affect nighttime pressure, urination, alertness, or balance. Alcohol can add another layer. A schedule that looks simple when one bottle is considered may behave very differently when the full evening list is placed on the table. If a change is agreed upon, ask how it will be monitored. The useful outcome is not merely a lower number at 1 hour. It includes daytime control, sleep quality, standing blood pressure, falls, kidney function when relevant, and whether the new schedule is sustainable. Sudden faintness, a fall, or very low readings deserve prompt contact with the care team. Adherence is the part many dramatic warnings miss. A tablet taken at a theoretically ideal hour does not help when that hour is so inconvenient that doses are forgotten. Use a pill organizer, alarm, or established daily cue if the prescriber agrees. If readings remain high or symptoms of low pressure appear, report them rather than improvising another schedule. The medication question is mostly invisible. The third habit announces itself with sound. Snoring is common, but loud, irregular snoring interrupted by silence, choking, or gasping can point to obstructive sleep apnea. During obstructive sleep apnea, the upper airway repeatedly narrows or closes. Oxygen may fall, sleep fragments, and the nervous system activates again and again. These changes can raise blood pressure and place repeated stress on the cardiovascular system. Sleep apnea is associated with hypertension, atrial fibrillation, stroke, heart failure, coronary disease, and daytime impairment, although an association does not prove that every event was caused by apnea. Snoring alone does not diagnose it, and not everyone with sleep apnea snores loudly. Other clues include witnessed breathing pauses, waking with choking, morning headache, dry mouth, unrefreshing sleep, difficulty concentrating, resistant hypertension, and excessive daytime sleepiness. Older adults may describe fatigue rather than sleepiness, so the pattern can be missed. Risk can rise with obesity, a larger neck, alcohol or sedative use, nasal obstruction, and certain jaw or airway anatomy, but thin people can have apnea as well. Women and older adults may present less dramatically than the stereotypical loud snorer. A partner observation of silence followed by a gasp can be more useful than the volume of snoring itself. The appropriate next step is an evaluation, not a purchase by yourself machine. A clinician can review airway anatomy, medicines, alcohol use, nasal obstruction, body weight, heart and lung conditions, and the likelihood of apnea. Testing may occur at home or in a sleep laboratory depending on the situation. Central sleep apnea and other sleep disorders require different reasoning, which is why the diagnosis matters. A phone recording can help describe a pattern, but a consumer watch or app cannot reliably determine the diagnosis or treatment pressure. A sleep study measures more than sound. Depending on the test, it may examine airflow, breathing effort, oxygen, pulse, position, movement, and sleep stages. That information separates obstructive events from other causes and shows whether the problem is mild, moderate, severe, positional, or associated with substantial oxygen loss. Continuous positive airway pressure, or CPAP, can keep the airway open and is an effective treatment for many people with obstructive sleep apnea. It often improves breathing events and sleepiness and can produce modest blood pressure benefits. Yet randomized trials have not shown that prescribing CPAP automatically prevents heart attacks or strokes in every patient with cardiovascular disease. The source promise of enormous cardiovascular protection is stronger than the evidence. Treatment still matters. Better sleep, safer driving, symptom relief, oxygen stability, and blood pressure are meaningful outcomes. The choice may include CPAP, an oral appliance, weight management, treatment of nasal obstruction, or other options based on severity and anatomy. Consistent use and follow-up matter more than declaring one device a universal shield. Comfort problems should be solved rather than silently abandoning therapy. Mask fit, dryness, pressure intolerance, nasal congestion, and air leakage often have practical adjustments. Some people need a different interface, humidification, pressure review, or another treatment. The useful question is not whether CPAP is glamorous. It is whether the selected therapy controls the measured breathing disorder and can be used consistently. Sleeping on the side may reduce events for some people whose obstruction is worse on the back. It is a temporary, low-risk adjustment for many, but it cannot establish severity or replace testing. Anyone with witnessed pauses, repeated gasping, major daytime sleepiness, or cardiovascular disease should raise the pattern with a clinician rather than relying on position alone. Breathing brings us to the fourth habit, the most visually persuasive myth in the routine. A clear glass of water on a bedside table looks harmless, simple, and protective. The claim is that drinking 8 ounces immediately before sleep keeps blood thin and prevents a nighttime clot. Hydration supports normal circulation, temperature control, kidney function, and many other processes. Severe dehydration can contribute to low blood pressure, illness, and complications. But there is no established clinical evidence that one bedtime glass prevents a heart attack or stroke by stopping the blood from becoming dangerously thick overnight. Hydration needs are not identical. Body size, food, climate, exercise, fever, diarrhea, diabetes, kidney function, heart function, and medicines all change the balance. Water in soup, fruit, vegetables, milk, tea, and other beverages contributes. That is why a single 8-ounce prescription, detached from the rest of the day, cannot define adequate hydration. The body does not turn 8 hours of sleep into motionless stagnation. Circulation continues, the heart continues pumping, and clot formation depends on far more than the speed of movement. Atherosclerosis, plaque rupture, atrial fibrillation, smoking, cancer, surgery, immobility, medicines, and clotting disorders cannot be neutralized by a glass placed beside the bed. Forcing fluid late can create a different hazard. More urine may mean repeated trips through a dark room, fragmented sleep, or a fall. Someone with urinary urgency may lose the rest that the routine was supposed to protect. A person with advanced heart failure, kidney disease, low sodium, or a prescribed fluid limit may receive specific instructions that conflict with generic hydration advice. Nighttime falls deserve special attention after 60. Low lighting, sleep medicines, a sudden drop in blood pressure after standing bare feet on a slippery floor, and urgency can combine in seconds. If bathroom trips are frequent, clear the path, use a night light, stand slowly, and discuss the cause. Preventing one unnecessary trip may protect health more directly than forcing an extra drink in the name of circulation. This is the thumbnail payoff. Bedtime water is not proven clot prevention, but avoiding dehydration is still sensible. Spread fluids through the day unless a clinician has set a restriction. Use thirst, urine pattern, weather, activity, illness, and medical guidance rather than a compulsory final glass. If the mouth is dry at night, a small drink may be comfortable. It does not need to become a cardiac ritual. Urine color is sometimes used as a rough hydration cue, but it is imperfect. Vitamins, medicines, foods, and illness can change color, and very pale urine does not always mean better health. Persistent thirst, very low urine output, dizziness, vomiting, diarrhea, fever, or sudden weight change deserves context from a clinician, especially in an older adult with heart or kidney disease. Frequent nighttime urination deserves its own review. Evening fluid, diuretic timing, diabetes, sleep apnea, leg swelling, prostate or bladder conditions, and heart failure can all contribute. Simply cutting off all drinks at 4 in the afternoon may worsen daytime hydration, while forcing water at bedtime may worsen nocturia. The cause determines the better adjustment. The glass exposes a broader lesson. A habit can be beneficial in one context, neutral in another, and harmful in a third. The fifth habit has the same problem because a thermostat setting that feels comfortable to one older adult may be unsafe for another. Very warm rooms can make sleep more difficult and increase sweating. Cold exposure can narrow blood vessels and raise blood pressure, and older adults may be more vulnerable to both heat and cold. Temperature can therefore affect comfort, sleep, and cardiovascular workload. What the evidence does not establish is one narrow range that guarantees overnight heart protection. Older adults may regulate temperature less efficiently, and some medicines can change sweating, circulation, alertness, or the perception of heat. A person who cannot adjust bedding easily has a different safety margin from someone who can. Fans can improve comfort, but in extreme heat, they may not be sufficient. Space heaters and electric bedding introduce burn and fire concerns when sensation or mobility is limited. The source specifies 18 to 22 degrees Celsius, or 65 to 72 degrees Fahrenheit, as if everyone becomes thermally neutral inside those numbers. Research in older adults is more variable. Clothing, bedding, humidity, climate, mobility, body composition, medicines, fever, and housing quality change what feels safe and supports sleep. Reviews of cold indoor exposure also caution that evidence is not precise enough to assign one threshold to every population. Aim for a room that is comfortably cool rather than hot, yet not cold enough to cause shivering, pain, numbness, or prolonged discomfort. Use breathable bedding and adjust layers before creating an extreme room temperature. During heat waves or cold spells, follow local safety guidance, especially if heart or lung disease, limited mobility, or medicines affect temperature regulation. Humidity and airflow can matter as much as the thermostat. A room may feel oppressive at one temperature and comfortable at the same number on another night. The better feedback is whether the person falls asleep, stays asleep, wakes sweaty or chilled, and can move safely. The thermostat is a tool for comfort and sleep, not a direct treatment for coronary disease. The deeper target is sleep itself. The American Heart Association includes sleep among its essential measures of cardiovascular health, and most adults need about 7 to 9 hours. A regular schedule, a dark and quiet room, less stimulating light before bed, and treatment of sleep disorders have a stronger foundation than promising that one thermostat number repairs the heart overnight. Now the 5 habits can be rebuilt without fear. Leave a reasonable gap after a large meal when your schedule and health allow. Take blood pressure medicine at the time agreed with the prescriber and prioritize consistency. Treat witnessed, breathing pauses as a reason for sleep evaluation. Hydrate across the day without forcing a bedtime glass. Keep the bedroom comfortable and protect enough regular sleep. The routine should also leave room for the fundamentals that carry much stronger cardiovascular evidence. Avoid tobacco, manage blood pressure and diabetes, take prescribed medicines consistently. Stay active within your abilities. Follow a supportive of your heart eating pattern and seek care for symptoms. A perfect bedroom cannot compensate for untreated hypertension or continued smoking, just as one imperfect evening does not erase years of healthy behavior. Notice what disappeared from that routine. There is no universal dinner deadline, no automatic switch of medicine to evening, no claim that CPAP eliminates cardiovascular risk, no water cure for clots, and no magic thermostat. Removing those promises does not make the plan weaker. It makes each action safer and easier to match to the person. Use one evening to collect information rather than overhaul everything. Write down dinner time and size, the actual medicine schedule, whether anyone hears pauses in breathing, how often the bathroom interrupts sleep, the room temperature, bedtime, wake time, and how rested you feel. A week of observations can produce better questions than a single anxious night. Then choose the most valuable next step. Reflux after late meals may justify changing dinner. Witnessed breathing pauses may move sleep evaluation to the top. Dizziness after an evening dose may require medication review. Repeated nocturia may point toward fluid timing, a diuretic, bladder disease, diabetes, leg swelling, or apnea. The 5-item list becomes useful only when it helps identify the one problem that actually needs attention. If chest pressure, severe shortness of breath, fainting, new weakness, facial droop, or difficulty speaking occurs, do not wait for morning and do not attempt to correct the problem with food, water, sleep position, or a medication schedule change. Seek emergency help. Bedtime prevention advice is never a substitute for recognizing an acute event. For the next routine visit, bring the record and ask which one change has the best evidence for your risks. It may be evaluating apnea, improving blood pressure control, changing a meal pattern, adjusting a diuretic, or protecting sleep. The answer may be different from the habit that first attracted attention online. Which of the 5 ideas had you heard before tonight? The evening blood pressure pill, the sleep apnea warning, or the glass of water for thinner blood? Share the category if you wish, but do not post private medication details or change a prescription based on another comment. A safer heart routine does not depend on performing 5 perfect tasks at 5 exact times. It depends on controlling established risks, getting restorative sleep, recognizing symptoms, and using personal medical information where generic advice reaches its limit. That is a plan worth carrying into tonight and every night that follows.